Well, welcome again to our Giants and Chest Medicine series. I have the privilege today of interviewing Dr. Marvin Schwarz. He's the James C. Campbell Professor of Pulmonary Medicine at the University of Colorado, former division head there. On one level, he needs no introduction. If you're in our field, you know who Dr. Schwarz is and his work. But Marvin, thanks for joining us today.
Glad to be here.
So we always have a series of different questions. Let's just start with the basic ones. Let's go back. How did you decide to even be a physician? And did you always know, or were you fell into it, or what were you, did you have a different career ambition as a little kid?
So my career ambition as a young child, and even going through almost through at least first 2 years of college, was to be a professional basketball player. When this became very clear that this was not going to happen, meant as a joke almost. But the reason I became a physician, I was told I was going to become a physician. My father and mother came here in 1938 from Vienna to escape the Nazis. I was born 2 weeks after they got here. And I think from the day I was born, and I was a man at that time, there were very few women in the field. A condition which has rightfully been corrected. I think it was always in their mind that I would be a physician, and I was driven towards that goal.
Your father's a physician?
Was, yes.
Oh, was.
Yes.
Your mother?
My mother was a concert pianist.
Wow.
Yeah.
And what kind of medicine did your father practice?
He was an obstetrician, gynecologist, but also a general. Back in those days, to be in OBGYN, you first had to be a general surgeon. So it was a subspecialty of surgery at that time. Yeah.
Wow.
Yeah, yeah.
Amazing. Any thoughts about being, following in the family business?
No.
Not at all, huh?
Not one bit.
Okay.
Never liked women.
Excellent. And was it a natural progression for you into pulmonary medicine, or did you, discover it along the way?
No. As I was going through my residency at Charity Hospital in New Orleans on the two-lane service, in those days you chose subspecialties based upon pretty much who you interacted with, and I had wonderful attendings in gastroenterology, and that was going to be my first choice. But then I started taking cardiology, and I actually had been accepted for a cardiology fellowship. And in the last part of my third or fourth year, I forget how many years of residencies we did then, I took pulmonary and was quite impressed with a man by the name of Dr. Morton Ziskin, who was part of our organization and a very prominent clinical pulmonologist. And because of him and my impression of him and that I wanted to be like him, I chose to go into pulmonary, and I stayed at Tulane to do that for 2 years at the time. And then I went into the military after that. Okay.
And then after the military?
After military, I was recruited by Tom Petty to Denver in 1972. And with many opportunities to leave, I couldn't think of a better job than I had eventually becoming the division head for 20 years. And working with outstanding people and outstanding trainees. So it was, to me, a perfect situation.
I think it's interesting. So we almost lost you to cardiology, huh?
Almost lost me to cardiology, yeah. But that, I saw the light, and and the thing I didn't like about cardiology was, I liked it, don't get me wrong, and I still do. It didn't give a broad enough sphere. I think the one thing that pulmonary medicine, and now of course critical care medicine and even sleep medicine, it gives you the broad range really of internal medicine. In terms of the ICU issues, in terms of all the systemic problems that can result in also pulmonary disease. So I found it a very challenging specialty. Can I just add one more thing?
Please.
And I still think that pulmonary critical care people are the best, other than primary care physicians, but certainly the best inpatient internists around.
I would obviously agree with you.
Yes, of course you would. I'm sure the whole society would.
Yeah, I think all our listeners and viewers are completely in agreement with you. There's a bunch of heads nodding as they watch this. So obviously then, arriving in Colorado and a wealth of amazing research and research opportunities, and clearly through your entire career,
yes,
known for many things, but take us through, if you will, if you want to encapsulate your research, where it started, what was initially driving you, and your interests evolved, changed, theories that maybe didn't pan out, change it, learn, move to another thing, etc. So if you want to summarize.
It's hard to summarize because that's about 40 years worth. So
right. How much tape do we have?
It's about 40 years worth. First of all, I was not that interested in physiology. I did physiology because back when I did my fellowship starting in 1967, there really wasn't much research. There was descriptive papers of conditions. Physiology was the really driving force of pulmonary research. There was no biology really at that time at all. So and as a matter of fact, I was even thinking about doing a PhD in a something, but what stopped that was the fact that I was in a thing called the Berry Plan, which was a deferment program for the military, and I had to go into the Army after I completed my fellowship, so I had to go, so that stopped that. So there really was only physiology, but Dr. Ziskin was very interested in chest x-rays. I mean, he studied x-rays, and I got into that with him. And then we came about these diseases called, I forget what we called them, I think diffuse lung diseases, possibly interstitial lung diseases. And we looked at these x-rays. Obviously, there were no CTs at that time to give us better definition. The pathologist really just called a thing called pulmonary fibrosis. They didn't really think about it very much, or right, didn't have the knowledge at the time. So the field was wide open in a sense that we knew that there were so many different conditions that can result in all this stuff, but we didn't understand it. We couldn't identify it other than finally looking at biopsies. As a matter of fact, in my informative years, including till now, my great interests, at least clinically, other than the patients, of course, is the radiography, and I'm still looking at slides. So pathology was extremely important to me because pathology raised a lot of questions in your mind. So basically, my whole career has been, at least my investigative career, which was mainly clinically descriptive types of papers for many, many years, was influenced by Dr. Ziskin and persists to this day. Talmadge King and I wrote the textbook, the first textbook on interstitial lung disease. The 5th edition came out several years ago. I don't know if there'll be a 6th edition, but I don't know if there'll be books.
Valid point.
In a couple of years. So a lot of that research was based upon correlation with histology, pathology, outcomes. We didn't do treatment trials then, corticosteroids, still until the IPF net did that, finally did a corticosteroid trial, in conjunction with other agents, that we realized that at least for what we call IPF, it was ineffective and possibly dangerous therapy. So we didn't know that, but that's what we were treating everybody with. And every once in a while, you get somebody that got better. So we say, well, let's figure this out. And that's when I started doing stuff. My first theory is that these diseases, since they were so similar, right, you know, at least in the way they looked and the way they looked on histologically, looked like the ones associated with connective tissue diseases. So I say, well, this is an isolated connective tissue disease of the lung. Just like you can have immune complex related glomerulonephritides, you know, that are not associated with a systemic disease. So right, I thought that this was happening in the lung.
Sure.
So my first foray into anything biologic was this, and I did it myself. We took biopsies and we did immune fluorescence and showed in some patients there was deposition of immunoglobulin and complement in the lung, dissimilar to what you would see in good pasture syndrome, in the sense it was right, it was immune complex as opposed to a linear deposition. And some didn't. And the ones that had the immune complex seemed to do better with corticosteroids. So what I suspect we were seeing at that time was an NSIP type lesion. And I think many NSIPs are associated with even undefined connective tissue right, diseases. So, and they could be more responsive to anti-inflammatory therapy. And then I think when Anna Katzenstein, you know, did this, dividing the histologic appearance of fibrosing interstitial pneumonias, the so-called IIPs, if you will, that was very helpful. I don't think that the histologic descriptions represent a specific disease. I think they were a reaction in the lung to a number of different insults. And I think the same thing for IPF. Even though there is a form of IPF which occurs in men, they're over the age of 60, they often are smokers, they often have honeycomb change on the CT. And by the way, that's macroscopic honeycombing, because we see microscopic honeycombing in a lot of these patients. Right. You know, that may be one phenotype of the disease. Now, with David Schwarz, who I have to tell you, it was the primary driver, and I've been working with David, who is currently the chairman of medicine at the University of Colorado. So that was very fortunate for me, because when I stepped down as head of pulmonary, I was really looking for something to do and so on and so forth. And then David came along, and I even spent 2 years doing a fellowship in his lab. When I was in my 70s. So I said, I want the title of senior fellow. So I did that, and I learned a lot about genetics, genetic techniques, and so on and so forth. And we've made some what I hope are, and then of course in our opinion, are very important discoveries, some of which have not even been published yet, that are in process of being reviewed by journals as we speak. And I think that we're going to change the whole field of idiopathic pulmonary fibrosis. I'm sure when people see this in a couple of, whenever it comes out, they say, well, he was right, or he's full of it. And of course, I've heard that before.
Right.
So we'll see if I'm right, but I suspect we will. And this particular polymorphism in the mucin gene, MUC5B, in the promoter region, the mucin gene, is a very exciting event. And now, using a GWAS technique, we have found about 9 different areas in the genome, a lot less than you would think we would find, which are ripe for exploration.
That's great.
Yeah. So
I think it's interesting because you, through your career, you saw this field change from barely descriptive, if you will, to individually kind of pathologically descriptive, with then obviously with CT coming along, a nice merging of that, intermixed with how people responded to therapy, and then now seeing it evolved where I think we all agreed it needed to go to a more molecular description, and maybe that is where we'll start to subdivide out these diseases. And
I think so. I think so. I think that we know a lot about the downstream events. A lot of people are studying pulmonary fibrosis. I think we know why fibrosis occurs. We know the proteins that are pro-fibrotic, et cetera, and I think that's a tremendous amount of contribution that a lot of people made. So I'm not diminishing those contributions. I think in the long run, those will be important. And I think the reason that those will be important in relationship with the upstream events, the genetic events. What happens? I mean, why do you get the same histologic appearance in rheumatoid arthritis, a UIP reaction, like you do in the so-called idiopathic? Why do you? One certainly is coming through the bloodstream, one would think.
Right.
And we think the others are inhaled, like in hypersensitivity pneumonitis. Okay. That's an inhaled disease, and you can get a UIP type picture as well, can't you? So I think we're going to see eventually coming out from all these studies, particularly the genetic studies, which will identify new pathways that can get to the fibrotic process. We know a lot about the downstream events. We've tried to treat those downstream events by blocking antibodies, receptor blockers, so on and so forth. Unfortunately, they've been unsuccessful, so far. There are trials pending as we speak now, and we'll see what happens with those. I hope they're a little more successful. But I think we're going to further divide diseases into different phenotypes based upon genotypes. And it's just not going to be for pulmonary fibrosis. It could be for tons of diseases across the board. And then eventually we're going to be studying these either by creating cells in culture and seeing how the cells react, cells from the lung or cells from the skin of people with lung disease, see how those cells react to various antibodies. Various treatments, not antibodies. Well, it could be antibodies.
That's true.
But anyway, my prediction will be is that I don't know, within the next 10, 20 years, that we will have this this personalized medicine approach, just like we have now with treatments of certain cancers. Right. We can predict now which patients will have bad drug reactions, say to azathioprine, by looking at something, which I don't remember what it is now, but that sort of thing.
Right.
So,
no, it does seem like that it'll be a natural play in all the growth we're seeing in the personalized medicine of tumors. Why wouldn't we see this applying into the other fields?
That's the future of medicine.
Right.
Of internal medicine, at least, and pediatric medicine, and so on.
You obviously have been a leader in this field for forever, and the multiple different achievements. If you had to pin it down to, you could only pick one thing that you're most proud of, is from an achievement perspective in your research career, what would be the one thing? Too
easy a question.
Okay.
Yeah, it's not what I've done for interstitial lung disease. It's the success of the trainees in the Denver program, which includes several hospitals, including National Jewish, the Veterans Hospital, for example. So these individuals, at least during my term, 17, became division heads, and 5 or 6 became chairman of some department of something. So that's really what my greatest pleasure was interacting with very bright people. Right. And contributing. Obviously, I would just make contributions to their development as academic physicians. So that to me represents the thing I'm most proud of.
Yeah. And the thing is too, as I know many of these people that and I'm sure our viewers do too, you know, without a doubt, they then obviously follow the same legacy of creating their own leaders within their own programs. And
Yes.
you know, you're absolutely right. You helped foster an entire generation of leaders within our field. So I want to then dive more into leadership, because you're actively involved with the American College of Chest Physicians and other organizations as well. What advice would you give for some of our people that are watching this who are earlier in their careers, so that they can get more involved with the ACCP or get more involved in pulmonary in general?
Yeah.
I'm your first year fellow. What advice would you give me?
Well, it all depends what you wanted to do, you know, what your goals were. So it's a tough question, but, if you said to me, I want to be a teacher, I want to be an academician, I want to develop a research career, or any combination of those things, you know, I think it's important to join societies, this and the American Thoracic. You should join those. These societies very clearly help you in directing you. I would choose programs that are to do a fellowship, which have a good record, and there are many in this country, certainly not just Denver. And that with a strong record of mentorship and success. The issue is, I think it's much tougher to become a successful academic physician, at least in the research arena. And I'm not just talking about you know, more basic research. I'm talking about, you know, good this genetic stuff we're doing is translational research.
Right.
So, you know, I think it's a hard thing to do under any circumstances, because I think you actually have less free time. I mean, you know, if you're doing it right, you know, the weekends sometimes, you know, when you're in private practice and your shift is over as the way things go now, or you don't have to cover these nights, you don't have to even think about it. And when your weekend is off, it's off. But in academic medicine, sometimes you're writing a grant, you're reviewing a paper, you're writing a paper, you know, et cetera, et cetera. Right. So it's a tough road. And I'm concerned, because I think a lot of the younger people today really don't want to make those kinds of sacrifices. I think that in many of their minds, and not all, absolutely not all, there are certainly people that feel the way I just described as the path to take, but there are many that really just say, you know, I've got my family, which always should be the most important thing, but sometimes medicine comes third or fourth on the list. You know, it's not second. Right. You know, your profession may not be second. So that's my concern nowadays. And what was your question? I forgot it. I've just been talking.
No, it's been good. It was the general advice on to give someone who's early in the field, early in the career, at various stages, and who says, you know, I want to be a division chief someday. You know, and what's it going to take? And I think what you just outlined, you know, because there's multiple pathways to that, but they all involve a serious amount of work.
Yeah, they do, a serious amount of work. And if you want to be in a leadership position, I think, you know, in the old days, in the days when I was coming up, you know, you had to be a really good clinician and be impressive and be able to be the go-to guy. And there's still some of that, but not as much. So you really have to have some sort of a productive investigative career. I don't care if it's clinical research, if it's clinical translational, or basic. I don't care what it is. But you've got to be able to do that and be eligible for funding. Now, I don't even want to talk about the problems that may be coming up with that, but you know, that can further influence people, and I don't blame them. Right. I don't blame them. I don't blame them at all.
No, it's the usual vexing problem. I'm sure some very promising careers have been steered in different directions out of concern for the constant struggle to get your next grant.
Absolutely.
In a shrinking funding environment.
Right, and as we're speaking here today, the sequestration is about a day or so away, and so we really don't know what the hell we're talking about.
Correct.
But there is one thing I would like to advise young people that that are turning in the direction of an academic career, but they're concerned about, boy, do I want to spend so much time and worrying about grants and papers and stuff like that. Once you're successful, it's a fabulous career. It really is, because as you get to be successful in academic medicine, as you get older, even though you don't have to do anything like me, your success, is already there, and people know about that. Not that we all have egos, but, and it's nice to be recognized and so on and so forth. But in private practice, just the opposite happens. As you get older, you're getting more tired. It's like, Christ, I've done this. So many times. I don't want to do this anymore, even though I'm only working 4 days a week or whatever the heck it is. So obviously there are financial differences. And the second thing I want to advise young people that are thinking about academics is that give it a damn good shot. Just don't go for the 3 years of fellowship and decide after 2 years, oh gosh, I really would like to do this, but blah, 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 my family wants me more at home. I don't know what it might be. You can always go into practice. Right. But if you change your mind, it's very tough to work the other way. So if you spend the 4 or 5 years in an academic institution, including your fellowship, say 2 or 3 years in a faculty slot, you can always come out. And there are always practice jobs right now. Right. There's not a problem. It's not a problem. You can always find a place, usually exactly where you want to live. So that's my advice.
I think that's excellent advice. Do you think, because we were just already talking, there's so many different things pulling on your time.
Yeah.
And so how does someone, and how were you able to do it, to strike that appropriate balance? Because you do need to obviously be able to focus on your family, but you need to be able to focus on that next grant or that busy clinic. Yeah. And then meanwhile, developing, leadership positions within societies and colleges. And, at some point you start to get worried. And I'll ask this question personally. You start to get worried. You're spreading yourself too thin. Yeah. That you're kind of good at a lot of things, but not excellent at the one thing that's going to push you forward. Yeah. Is that an issue of mentorship? Is that an issue of establishing what your priorities are and focusing on it?
That's the easy way for me to answer. Sure, it's what you want to do. In other words, if you enjoy doing what you're doing right now, for example, right. That's great, but if you want to have an investigative career and be known for that and write papers, get grants, you're going to have to be a little circumspect in spreading yourself too thin and doing a lot of administrative stuff, whether it's at your own institution or for one of the societies, the college or other societies that you may belong to. You certainly want to take the opportunity to present outside of your institution at every opportunity that you get. But in terms of being an officer in, say, the college, does that take too much time? Do you have too much traveling to do? I never chose to do that, and not that I'm saying I would have gotten to that level, because I do offend some people every once in a while, but I never thought even consider doing that. I was much too busy with the stuff we were doing, with the fellows, and running a division with 120 faculty. Yeah. I just didn't have the time or the energy to do a whole lot of other stuff.
Would you do it all over again?
Oh, absolutely.
Would you change anything?
Nothing.
Fantastic.
Nothing. I wouldn't change anything in my life. The only thing I would change is I wish I was 6'6" and I could have played. At least for a while.
Gave it that good shot. Right?
Give it the shot, yeah.
That's fantastic. So tell me where you think this, I'd like to have your vision for where academic medicine's heading, because it's obviously, you've seen it change from when you first started to when you left your position as division chief.
Yeah.
And I'm wondering whether you think it's moving in the right direction globally or wrong direction. And
I think globally, from what I understand from my European friends and colleagues, is that whatever is happening, that we see happening in the United States in terms of training and attitudes of younger people is the same thing that's happening, at least in Europe. I can't speak for Asia, et cetera, but I can at least anecdotally tell you what people tell me.
Yeah.
They basically have the same complaints that we have. You know what I find fascinating to me is I speak to my fellows who are, either 1 year, 2 years, 3 years out from, being a resident or being a chief resident, and they're complaining about, the kids that are only 3-4 years behind them, and and I think the way things have changed, and I'm not going to blame certain organizations, which I am already in trouble with, like the ACGME. Who have absolutely changed it to the point which I feel that while internists have a more narrower scope of what they're supposed to be able to do,
right.
But I still am concerned that they're not learning and they're not engaged. It becomes a job. They're not engaged in their patients. And I'm sure this happens across at least academic medical centers. I can't speak for any others than my own. We have very good people, but the teaching is done by hospitalists. The specialists never, almost ever have contact with the patients, because when we see their patients, it's in the afternoon, and the persons that are on then don't even know these patients unless they're desperately ill. Then they know them, So we're writing orders. We never speak to them to try and teach them about something, Right. So I'm very concerned. I'll tell you, when I came out, and I grant you without question, there was so much less to know than there is now when I finished my residency. But I felt, boy, I could handle anything. I didn't have to call anybody to do anything if I really didn't want to. And I don't think that's not the case now. So I don't know. I'd be very concerned if I was an internist, at least. Maybe not so in the outpatient environment, but in the inpatient environment, right. I'd be very concerned, because people that are coming to hospitals are much sicker than they used to be. We're really admitting people that are sick as dogs. Right. They're just sick as hell.
No, you're right. I mean, to get into the hospital these days,
you got to be sick.
You got to be pretty darn sick.
And they need care, and they need it around the clock, and it's got to be good.
Are you worried at all that the shift in priorities with a focus on duty hours, as it will, as opposed to direct patient care? Yeah. Are you worried about that also, or have you seen it influencing that level of inquisitiveness that we need to see? I'll take care of my patient, but also, why is that happening? I'm going to go research that, and then boom, a career develops.
Well, I think there's still some of that.
Sure, there always will be, obviously.
Because people are still opting to go into subspecialty where they get intensive training and they can be experts in an area. So I think that very clearly happens. The need for subspecialists is going to rise tremendously, because I think of the limits they put on general internists, right. And how much they can learn and so on and so forth because of the restriction of hours. So I think there's going to be a tremendous need for subspecialists. I think that if we just talk about ours, you know, which is one which financially probably sits somewhere behind 2 or 3 others, I still think we're going to see, you know, a continuing rise in the number of individuals in this country who do it. But what my major concern is that the academic enrollment of these people is going to go down. And we still need those people around. You know, I mean, if you just say, oh, I don't care about the research, say, I don't care about but somebody's got to do the teaching, somebody's got, you know, so it's still, and I think that a lot of people that finish fellowships now don't do a tremendous amount of research, but they like teaching, you know, and they like seeing patients, and, you know, and that's fine. I mean, I'm all for that. We need those people around. I mean, we need them, and you know, as long as they can be happy in that type of career as a clinician educator track.
What else should we talk about? What have I not brought up, or something just when you were thinking, you know, what this was going to be involved with? You know, something you said, I wonder if he'll ask me about this. Is there something that we should be talking about further that I haven't asked you?
No, we shouldn't be talking about those things. No, I think that I think you've covered views, some of my political views, and so on about what's going on and my career. You know, the only thing I would like to say if we're getting close to the end is that, and I know this sounds trite, but I have made so many friends, and I'm sure quite a few enemies, that it has enriched my life, you know, being with these individuals. Even I don't see them every day, but a couple times a year, I've really enjoyed that aspect, the camaraderie of people doing the same thing and having the same problems and hopefully the same successes. And I think our subspecialty and the 3 components so far of our subspecialty are going to continue to do very well. Yeah. I really do. I really do.
Take you so much.
You're welcome.
We really appreciate your time.
And I thank you for being selected to do this. I think there'll be a lot of people say, what, are you kidding me? Him?
Well, I say it's, I think, what did Peter Barnes said? It was a dubious honor to be on this list, this Giants of Medicine. He says, does that mean I have to be semi-retired? What I have to?
Well, Peter's been semi-retired for years. He just doesn't know it yet.
Fantastic.